Are we?
Yes.
Where are we?
Here.
Why are we here? Not entirely clear. We are misfits thrust into existence by random chance, with no hints at all as to how we're supposed to make sense of it all. It's immensely bizarre. Here we are.
Hello, everybody, and welcome to the Here We Are podcast. Have a very special episode for you today, mixing it up, doing something different. This is a really important episode for me. I have joining me Associate Professor at Stanford, Dr. May Han is joining me, who is expert on multiple sclerosis research. May, thank you so much for joining me today.
Thank you for the invite. Great to meet all of you, especially you, Shane and Megan.
And I have a special, I have one of my favorite people in the whole wide world joining me. Here's a little bit of a background story on what's going on. So I've had a few good friends with MS in my life, Megan being one of them, and I've been wanting to get a researcher on forever. I asked around, and I got referred to May Han by my favorite scientist, Robert Sapolsky, who listeners always hear me blabbing about and raving about. And I told Megan all about this podcast coming up, and she was so jealous that I got to meet May Han. And I was like, well, I don't know anything about MS, and Megan's someone who has spent years kind of doing so much of her own research and dealing with her own condition, figuring out all of what kind of works for her. And so joining me as well is my friend Megan. Hello, Megan.
Hi.
And so Megan's going to help me out. I don't know anything about MS other than just I've never read a lot about it. It's one of those intimidating but important subjects for me. So it's a wonderful opportunity to have someone with experience and someone that actually has done their research a little bit, helping me with some questions. So to get started, Mayhan, could you tell me and the listeners a little bit about you, what you do, and your experience?
So I'm a physician treating patients with multiple sclerosis. So that's what I specialize in. I take care of patients who, present with, neurological conditions of the nervous system, most of which are multiple sclerosis patients.
What else do you research? What other neurologic issues? So
my specialty is called neuroimmunity, or basically anything that causes autoimmune conditions of the brain, where the immune system attacks the central nervous system. So, I do research on the topic of autoimmunity of the brain and disease-wise multiple sclerosis and neuromyelitis optica spectrum disorders.
Can you tell us what is multiple sclerosis?
Very good question. So multiple sclerosis is a nervous system disorder. So, very briefly, you can consider the nervous system as the central nervous system, which includes the brain and spinal cord, and the optic nerve, the nerve that gives vision to the eyes. That's the central nervous system. And the peripheral nervous system is the nerves that come out of the brain and spinal cord and supply the rest of the body. So I specialize in the central aspect of it, so brain, spinal cord, optic nerve. And basically, multiple sclerosis is a condition where the immune system starts attacking the myelin in your brain. So, as you know, the immune system is there to protect you from the, inflammation of the immune system is there to protect you from like the foreign proteins like bacteria, viruses, and, anything that can cause harm to the body, such as, infections. to begin with. But then when the immune system kind of gets confused, it starts attacking the self-tissue, thinking that it is foreign. That's when you have a condition called autoimmune disease, where the immune system attacks the self, autoimmune, self-immune system attacking the self. So, there are many autoimmune conditions, such as, lupus, systemic lupus erythematosus, where you attack the immune system attacks the joints and the kidneys and the skin. But in MS, the myelin, the covering of the nerve sheets are attacked by the immune system. So that's why you would probably sometimes hear the word demyelination, meaning immune system attacking the myelin and removing the myelin, demyelination or loss of myelin.
So this is the fun part of the show where I'm going to try to explain how I think something works, and then you get to correct me. Always, so myelin's like kind of it's this little covering kind of spaced out on a neuron, and the electricity kind of it speeds up the signal. It's kind of making the signal jump across the axon or dendrite. And so when you lose that speed of the signal delivery, correct?
I think you said it really well. The way I would see it is that the signal is made in the nerve cell, right? But then the signal has to travel to the different parts of the body. So in order for the nerve conduction to go fast, you have the ensheathment around the nerve fibers, almost like an insulator. So you can kind of think about a wire. The metal part would be the axons, the wrapping of the plastic is the insulator. The myelin's like that. So myelin's made out of lipids or fats, very special kind of lipids to make the nerve conduction go really fast. So, anywhere in the brain and spinal cord and optic nerve can be attacked by the immune system. So when that happens, you have loss of function of that particular nerve fibers or nerves. So let's say, for example, right, in MS, if the optic nerve or the nerve that gives the vision is attacked by the immune system, you'll lose vision, right? Whereas if the sensory part of the nervous system, nerve fibers are attacked, you'll have numbness. The same way, if the motor fibers, nerves that help you make motor movements, right? If it's attacked, then you'll have weakness. So that's why it's very confounding. It's basically immune system attacking the myelin in the nervous system but you don't know where it's going to be attacked. So one patient may have optic neuritis and vision impairment, but the other person may show up with numbness, or the other person with weakness or paralysis. So, there's a theme that threads through all of those symptoms, but the outward production is different. So that's why it's so confounding. Another feature is also it's the relapsing remitting, feature of the disease, which is almost like kiss and run, because the immune system would attack the myelin. The symptoms would last from weeks to months, and then it resolves. So after a month and a half, the symptoms go away. So, it's also like it happened and then it's no longer there. So the episodic feature also makes it really confounding.
Yeah, it just seems like there's so much individual difference with MS, more so than so many other ailments in life. So, Megan, could you introduce kind of just a little bit about some of your background, and maybe it'll help kind of give May some context too, and I'm sure she'll have lots to say about it, but just kind of when things started happening for you, what your experience was?
Yeah, it'll be 5 years this summer. I was in this car wreck, and I wasn't really injured physically, but it was pretty traumatic emotionally. And I would say within a month or so, I started having some like brain fog and some weird physical symptoms, some numbness and tingling in my fingers. But concurrently, a lot of other weird stuff was happening to my body. My joints were popping and cracking and this, and this. It was like dominoes, all these symptoms. And I was diagnosed with a connective tissue disorder called Ehlers-Danlos syndrome. And at the time, I'm, seeking answers. I'm asking for nerve conduction studies. Why are my fingers, do I have carpal tunnel? What's going on? And at the time, my doctor was blaming everything on the Ehlers-Danlos and really kind of was encouraging me to drop any investigation of anything further. And I had some intuition or something to keep digging. And it was very bizarre. I mean, she was asking me to just take these pills. If we can get rid of the symptoms, just drop it. And I was like, I need to know. This doesn't feel like just Ehlers-Danlos. So I found a neurologist and I came to him with my theories, which were a B12 deficiency or this, whatever. And he ordered a brain scan and a C-spine scan. And I was like, well, that's weird. Why would, and throughout all this time, this was going on for maybe a year, like symptoms, seeking answers. I had never once sought out MS. I just was like, it just didn't even enter the realm of possibility for me. So he called me on a Friday and said, yeah, you've got some lesions on your brain and he's talking a mile a minute and these are enhancing and this, and this. And I was like, and he's like, I think you have multiple sclerosis. And I just was floored by that. It just didn't even seem real. And, it was pretty devastating to hear, but I spoke to a friend of mine who's a neurologist and another friend, and they said, you're going to be okay. They talked me off the ledge and said there's, the MS of today is not the same as it was 20 years ago or even 5 years ago with the new treatments that were available. And I was able to get into a clinical trial for ocrelizumab, and which had already been approved, but getting into the trial meant a speedier, ability to get it approved. So I was started infusions a few months later, and I've had one or two like definite relapses early on in the treatment course, but since then, not a lot of new disease activity. And I just, I sometimes feel like the luckiest girl in the world. But I also take low dose naltrexone as kind of like an adjunct therapy. And since then, I've totally overhauled all these other areas of my life to try to control what I can control with diet and exercise and mindfulness and stress reduction and things like that. And but I'm very interested in research, and this whole thing with my health has just reinvigorated a love of science for me, and health and medicine and all of it. So when Shane told me he was interviewing you and I looked at your bio, I just was fangirling pretty hard and just am very impressed with how you spend your time and very thankful, really.
What are common symptoms? How does Megan's story kind of compare to average occurrences? And it sounds like there isn't really the word average is kind of hard to use when it comes to MS.
Mm-hmm. Well, yes, Shane, I'll try my best to address that. But first of all, Megan, I just want to tell you that, I'm so proud of the journey that you have come so far. And, my heart goes out to you every time I see a new patient, and I hear the story along the similar lines, I am humbled. As well as reinvigorated, to help cure this disease. And, I've seen you for less than 5 minutes on Zoom, but I think you're doing all the right things. And I agree with your two friends. You will do really well. I think you've addressed all the components of multiple sclerosis. It's really not just MRIs and Ocrevus, as the mind and body connection, the other, important aspects that you've honed in. So we can delve into it as well. So I just want to, give you a shout out, and just to let you know that, my heart kind of leaps when I hear those stories, but also I totally feel elated to hear, in your short journey, how well you're honing in, and you're turning it around and making it a positive journey for you. So thank you. Okay.
Yeah, thank you.
So getting back to, Shane's question, how unique is your presentation, right? So I always say that, I do this for a living, and I've amassed quite a bit of experience, but I would say no two people walk into my clinic with the same presentation. So every case is unique. But if you look at it, as a MS physician, are you okay? Megan, are you okay?
Oh, yeah. I'm very emotionally charged. I don't know. I'm very affected.
No, it is a personal story too. So if you need a little break, let me know.
Oh, no, I'm okay. I'm just a crier anyway, but it's just, I just am very honored to be sitting here with you and just to be talking to you.
No, it is cathartic to share stories,
Yeah.
So well, go ahead.
Megan's also in the best shape of her life. Really, she's taken this as a incentive to. I don't know how much I should share, but quit drinking and started exercising like crazy. And she's one of the most regimented exercise wise person that I know, and has just been really on top of nutrition and everything else. So it's who knows if you'd even be in as good of shape as you are right now if this hadn't happened.
I wouldn't be. I mean, all of this health stuff has been, in many ways, I say this all the time, it's the worst thing that's ever happened to me, but in the same token and to the same degree, if not more, it's been the best thing that's ever happened to me on so many levels, spiritual, physical, everything. And I feel lucky the breaks that I've gotten with getting in that clinical trial and the amazing doctors I've had and the ability to exercise and the time to do it. Not everybody has that time or any of that. So it's, and just the time in which in our lifetime that I got this, people 20 years ago that could have been my same position in, with the same symptoms and the same timing of a doctor getting the MRI, they would have just had a totally different progression. And I feel really lucky and even luckier for what's to come. So, yeah.
Isn't it a bit of an antithesis, huh? Like you would say that you get this, you said, it was, you summarized it in one sentence when you said that when you were on a Friday evening telephone call, when the doctor was telling you about the enhancing and non-enhancing lesions on the brain MRI, and said you probably had MS. You said that was not part of my vocabulary. And, I could not wrap my head around it. And, that clearly, succinctly described your state of mind. And yet, right, a few years later, you turn around and see that this is the best thing that ever happened to me, right?
Oh, I know.
And I have heard those stories before. And I think that, in order for patients to get to that state, I think it's a team effort. I think most of the credit goes to you, but I think you also had really good guides, including your care team, your doctor, your friends, your supportive environment, not just the medical aspect of it. So, it takes a village to take care of a MS patient, so I think that, what you can contribute is if you can share your story to, somebody who was just diagnosed with MS and just had their world turned around, turned upside down. If you can empower them, I think it's really, really important.
Yeah, I spend a lot of time in these Facebook groups for different parts of my health thing, and I mean, I use it for my own resource and HiveMind and things like that, but I spend a fair bit of time offering up exactly what you're saying, because it's, you know, that kind of stuff was instrumental to me early on. I mean, it still is, but, and a lot of people don't have MS specialists. They see a neurologist that might, you know, out in, you know, if they're in rural Kentucky or something, and they don't always get the best guidance. And it's weird to say, but like often some of, like, you know, these groups can help guide people, even just saying like, find an MS specialist, like, cause they're recommending like Copaxone or something as a first line treatment. And that might not be appropriate anymore, but because they're dealing with 45 other neurological diseases, they don't have the time to go to the MS conference or, you know best practices. So it's, but yeah, being, and I share my story also to people very freely, because they might be, you know, I've got this numbness and tingling. I've had it for 3 years, but it's probably carpal tunnel. And I'm like, wait a second, maybe it's not. Or, you know, I found out a year ago that I have narcolepsy without cataplexy, and I've gone probably 25 years of my life with it, thinking I'm just tired and lazy and a terrible person. Because no doctor ever thought to send me to a sleep specialist. So now I tell anybody that will listen, hey, if you're tired all the time, there might be a reason for it. Like, seek answers. Because
absolutely, you know, and I think it's like, it matters so much, you know, and I always say that I know a lot about MS, but, you know, I have never been in your actual shoes. You know, but coming from you, right, even little tips, oh, I have the symptoms, but I did X, Y, and Z, and maybe you want to try it too. I mean, I'm not saying, you know, like out of ordinary treatments, but even, you know, little tips that you can share, or the coping skills. You know, it matters so much to the MS patients. You know, even if I want to help, I am not, you know, I would not be able to help as effectively as you can, like, you know, helping peer-to-peer. It's basically peer-to-peer mentoring, you know?
Yeah.
I've told her that she needs to write a book about her whole experience all the time.
We will be cheering on.
So May, what are the various approaches? So someone comes in, first day, someone comes in, they have MS, you're going to be working with them. What are some of the first steps? If it's expressed in so many different ways, I imagine there must be so many different tools you must have to have in your toolkit, and then work through trying to figure out which one specifically is going to work for a given individual. There's probably a lot of trial and error. How does that whole process work from your end of things? Yeah,
you know, it's really interesting. You know, initially we all started out thinking that, you know, the more sophisticated you are, the more tools you have, you get close to the diagnosis. And I think there's a lot of truth in it, just like Megan shared, right? You have to get to somebody who's thinking about having MS in mind, right? Like a neurologist who's specializing in MS or cognizant of MS symptoms. Number two is like things like MRI are very important. Blood tests that can rule out MS mimics, because Shane, we don't have one blood test for MS, but we have other tests that can look like, to rule out conditions that can look like MS, like infections, other autoimmune conditions, because those can be quite easily, you know, with a blood draw, you can rule those out. So by exclusion, MS becomes the diagnosis. I think all of that is very important. But, you know, the longer I do this, what I've realized is the most important thing is, as a physician, to have an open mind, not to have preformed ideas, and listen to the patient, you know, and listen to what the patient is trying to tell you. And, you know, a lot of the times you kind of have to pick out the important things out of 1,000 things that they tell you. But I think the important thing is you have to listen to what the patient is trying to tell you. So patient first approach, right? And Shane, you're right. It comes in so many different flavors, but there is a common thread to it, right? So common things being common. You see somebody who is, you know, in the, you know, age that where you see is common. MS commonly occurs like in young adults during the reproductive age. But mind you, MS can occur in very young and very old as well. So you can't exclude that either. But then when they have these symptoms that come on quite suddenly, within hours to days, and then stays on for, weeks to a few months and then resolve, right? Like, so visual symptoms are really, so, we have the code words or telltale signs. If somebody comes and tells you like, oh, I have like, I have blurry vision, like a black curtain coming down. I woke up with blurry vision in my eyes and I thought I had oil in my eyes. Or, when I do this and this, the one eye is different, or if they say I woke up with numbness waist down, or, you also hear these stories that, I don't know why, but I've always been, my balance has been off and I fall often, if that happens like after delivery during the postpartum period, or, sometimes after infection. So those are the things that should raise a red flag. The rest of it is the good old thorough neurological exam. You don't skip, you go step by step. You examine the patient thoroughly, you listen to them, and that is probably the 80%, And also you have to have in your back of your mind, you have to have a high index of suspicion, and the rest of it is the sophisticated tools like the MRIs are very helpful. Not only do they tell you, that the brain and spinal cord and optic nerves are involved. We know whether it's an active disease, if they are active or enhancing lesions, if there is chronicity, such as, if you have brain atrophy, whether brain is involved, spinal cord is involved, how many, how much, in a sort of a quantitative manner. And the spinal fluid too. We don't always do spinal fluid analyses, but, in order to basically, MS is basically, you have to have neurological episodes that are separated in space and time. Space meaning one time in the optic nerve, another time in the brain. Time meaning one is an active lesion, one is an inactive lesion, or two separate episodes. So, if you meet those criteria, patients get diagnosed with MS. And then the journey begins.
Well, that was one of when I put a kind of feeler out on social media for questions for you. That was one of the things I saw come up a couple times was does MS sometimes, what does MS sometimes get confused with? Like I think someone mentioned Lyme's disease in particular. And Megan, did you?
Yeah, when this was all going on, that was a suspicion. I had a dermatologist because I had gone to see him for something, mole check or something. And I was telling him just in conversation, I'm having all these weird symptoms and this, and this. And he was like, you might want to find out about Lyme disease because it's becoming an epidemic. It's everywhere. It's not just in these pockets of the country. And so I took that to the neurologist that I saw at this appointment, and he had ordered the MRI, but he also ordered the B12 testing and he ordered Lyme disease testing, but he didn't order it in the correct, like I would have failed it if he had ordered it in the right way, but he ended up doing like the Western blot, and I had tested positive for all these bands. And so I got a call from the Ohio Department of Health before I found out about the MS, asking me about my Lyme disease. I was like, what? My doctor said everything was good. And so that ended up throwing a wrench into the whole diagnostic process, because we were trying to piece these things apart. Do I have Lyme and MS? And eventually they basically convinced me to just drop the Lyme disease thing because I don't know, it wasn't convenient, or I don't know. I still don't know what happened with that, but my symptoms seemed much more closely aligned with Lyme disease. I mean, I was having like Achilles tendon burning and all this weird stuff. And all my MS symptoms have always been bilateral. So, who knows what that's about, but
you had quite a tortuous path as well, to say the least, early stand loss and car accident and,
and then lumbar puncture to diagnose the MS caused a 6-month CSF leak battle.
Oh, I'm so sorry.
That's, we can, courtesy of the Ehlers-Danlos, that I didn't seal up like they thought I would. And that was a whole nother journey.
You were like on your back for 6 months or something like that, weren't you?
I was buying upright time with Diet Coke and caffeine pills to stand, to be upright for a little bit.
No fun.
No, but it made me stronger, and I'm here to tell about it.
So May, what are some of the, does this happen where people confuse various things with MS, or especially Megan had mentioned early on that she feels lucky that she is in this time in history with all of the modern tools and everything. I imagine it was a lot more to home in on.
Very true.
Years ago.
Yeah, I mean that's almost like before we diagnose somebody, before we give a confirmatory diagnosis of what we call the clinically definite MS, we have to rule out other MS mimics. So Lyme disease is one of the on the list. So we rule out infections like Lyme disease, inflammatory conditions, other autoimmune conditions like lupus, rheumatoid arthritis, and hyphospholipid antibody syndrome that can also give you like white spots in the brain, can mimic MS. All of those have to be ruled out. And also the other thing too is, just like Shane mentioned, in the old days, it takes like 10 plus years for somebody to get to the diagnosis of MS, because, you have an attack, 2 months later, you're better. You haven't even seen your doctor, the symptoms go away. And then next year you get another attack in a different, in your different part of your body. So it goes on for a while before you get diagnosed with MS. So, when you see somebody at that stage, like 10 years out, most of the time it's a classic MS, most of the features are fulfilled. But these days, I think people are a lot more aware of the disease. They pay more attention to their body. The knowledge is out, not just for the patients, also for the treating physician. So you get to the diagnosis earlier, and also the tools are available. But you also see a lot of the atypical cases or early cases that have not fulfilled all the criteria, So in those cases, it is also a responsibility, right? To diagnose somebody with a disease, you better be sure, you better have no stones unturned. So definitely we have to fulfill these. Not only ruling in MS, you have to rule out other things that can mimic multiple sclerosis.
So I had this fantastic episode at the beginning of the year with Michael Snyder with Stanford Health, and I ran out and got a smartwatch right afterwards, and haven't looked back, and love the idea of it. And the idea was, this is a way of with simple measurements like changes in your heart rate, you can potentially detect a virus, a cold, Lyme's disease, COVID, various other ailments before, notice a change, maybe not know exactly what it is, but notice a change that you want to attend to before symptoms take place. And this is also, not only is this great for, say, with COVID going around, where you can be even that much more careful about quarantining yourself until you've been tested and everything else, but you can also kind of get a jump on whatever the best treatments are. And like COVID has different treatments for different stages of it, and I imagine MS is a similar thing. What has happened in the last several decades or so, or just in recent modern medicine that has helped dial in earlier and earlier detection of MS, and what are some of the things that can be done when it's caught really quickly, versus when it's gone on for a while because maybe someone ignored their symptoms or didn't go in early enough?
Yeah. Yeah, so I would use like a multi-pronged approach. The first part is we discussed it a little bit early on, like education, right? Like patient education and, educating the physicians to be aware of the symptoms when you have them, not to ignore them, ask for medical attention, whatnot. The second aspect is the diagnostic, from the diagnostic aspect, right? Can you predict MS, right? Can you predict who's going to have MS, right? Or can you even catch the earliest stage of MS, the preclinical or prodrome state, right? So that they don't really move into the state of MS. So before I do that, I'm going to share a little bit of the lingo. So, Megan, you probably are all over it. So please just ignore it. So basically, in order to meet the diagnostic criteria for MS, the multiple sclerosis, so you have to have multiple attacks, right? But sometimes you see the patient after the first episode, right? Either a clinical episode like a vision impairment or weakness, or just, like somebody was in a car accident or had headaches, went and scanned the brain with an MRI and you see a lesion. So incidental findings, right? So that's called a clinically isolated syndrome or radiologically isolated syndrome. So big words, but bottom line is it's the one-time event. That one-time event can stay as one-time event and not turn into MS, or can progress into MS. So Shane, just like you said, you had mentioned very pertinently, it's really important to catch it there, right? Because you want to catch it as the CIS or clinically isolated stage and then not get into the multiple stage, in which case it would not be you won't have to treat somebody permanently with a medication, right? So MRIs have become really helpful, right? Like in diagnosing, somebody has a symptom, you catch them early on with the MRIs, but we want to precede that, right? We don't want to wait until somebody has a lesion in the brain, because you have one brain, it's a permanent organ. We want zero damage to the brain, right? So if we can diagnose a blood test, right, where we can look at the immune cells, we don't have it yet. Or if we can look at the genes, and if we can predict, right, your immune system is kind of going, awry. So can we kind of tilt it back on the thermostat so that it gets back to the normal, healthy, or homeostatic stage? So that's really important. That's what we're really interested in. We're really interested in blood biomarkers or genetic biomarkers that we can predict. So basically, we have a few clues now.
Oh, clues. Okay.
Yes. So like low vitamin D deficiency is strongly associated with multiple sclerosis. So a lot of a large population of the MS patients have vitamin D deficiency. So vitamin D is not just used as a vitamin. It is also an immune regulator. So it keeps the immune cells in healthy state. Okay, so vitamin D is one. The other component is the infections. And Epstein-Barr virus has strongly been associated with the incidence of MS. It's really hard to parse out because 95% or so of the general population is positive with Epstein-Barr virus, or the virus that gives infectious mononucleosis. 100% of the MS patients have had at some point had EBV or mono. Okay, so we don't really know whether it's a direct causal or it's an association, true, but unrelated, right? But it is very intriguing, because whether an infection has kind of, turned your immune system off to a bad immune state where it starts attacking the myelin. Okay.
I remember reading something, which I'm sure I'm butchering, 15 years ago or something, and I'm sure everything's come along quite a bit since that time. But it was something like they were seeing a trend between people that had some sort of severe illness as a child, like 9-10 years old, kind of like you said, mono or something, and then MS expressing again, and or those people starting to express MS in their, often late 20s or so, and there being kind of, I guess like you were saying, not understand, correlation, causation stuff, not knowing what was going on there. Is that still some of the case early on in child? Is that what you were kind of mentioning?
Not so much like early on or childhood, like around the time of the, several months before the initial onset. It's almost like there's an immune hit. So I would always ask my patients prior to this, what do you think happens? Because a lot of the clues you get from the patients, like go back, think about it, what happened around that time, and they would, I would say 30 to 50% of the times there's some, infection or immune activation. They would say, I was down with this infection. I don't know what it was. I thought it was a really bad case of flu, but then I started like 2 months later, 3 months later. So, we make a mental note, we write it down, but we have not proved it directly that this infection is causing, the neurologic episode, right? So you do hear that, but in half of the patients, they also would say, I can't really pinpoint to anything. A lot of the things that you hear is also stress. This is the most stressful time in my life, right? Like that's like the common theme, so stress is not good. Stress and MS don't go well together.
What about I know it's often kind of this exaggerated, often false dichotomy of genes versus environment, and I know it's always both are playing a role, but is there with as genetic testing advances, is MS something that seems to run in families at all? Is there a genetic component going on?
Yes, so definitely, we've known it since the, late 60s, 70s, that HLA genes play a role, in, as a MS susceptibility gene, but then not everyone who has the susceptibility gene ends up having MS. So it's almost like, it's a, basically you have to have two double hits. So you have to have the susceptibility gene and you have to have the second hit. That second hit can come, I think, in a variety of ways or a combination of a few. To name a few, vitamin D deficiency is one. Infections could be the other. Stress has been shown to turn the immune cells from good cells to bad cells, and also obesity and hormones. We learn quite a few things about MS through hormones. So, women, it usually occurs in women during reproductive age. In general, it can occur in either end of the spectrum. Pregnancy is protective. After delivery, patients end up having relapses. So hormones do play a role as well. So those are the, to name a few second hits, you do need to have the, basic susceptibility gene, but having that itself is not enough to, elicit or to mount a disease or to push somebody off the cliff to have the disease. The second hit could be infections, vitamin D deficiency, hormones, and stress.
I have a few more questions. I want to give you an opportunity to jump in, though, if you want, Megan.
Man, I mean, I could think of 1,000 things. But yeah, why don't you ask what you?
All right. Well, I have something that's on my mind as you were talking about other doing your research expands into all sorts of neurologic conditions. What do you have any takes on anything coming out about COVID? And I know that there's been some neurologic issues associated with some of the COVID cases. Have you taken any interest in that at all? Do you have anything you could share?
Yeah, because right, like COVID is so much around us, right? Like it pretty much runs our lives now. So what affects my patients affect me as well, right? So a few things that I can share with, this is also something that we all are learning together. So it's just been a little over a year. So, but what we have known so far is just because you have MS, it doesn't increase your risk of getting COVID, okay? Just because you have MS, it also doesn't mean that you're going to have more severe disease, okay? So National MS Society and quite a few of the MS specialists from Europe as well, they've come in and they've shared their experience. Most of the immune modulatory therapies or MS drugs don't directly impact. But, of course, we're more concerned about patients who are on, infusion therapies, biologic therapies, basically we're removing a part of the immune system so that, these cells don't attack your brain and spinal cord and give you MS relapses. So, in that sense, we have changed your immune system in a certain way. So we do worry that, will it affect the, how COVID impacts your body? And also not just that, together with that, the vaccine response too, right? Now that the COVID vaccine is out and we're all racing to vaccinate as many people as fast as possible. So some of the therapies that we use to treat MS patients remove B cells like ocrelizumab, Ocrevus. So those are the cells that give the vaccine response. So, it requires careful planning, when they get vaccinated, when they get their infusions, because, we don't want the MS to get worse. So they do need their therapy, but they do need their vaccine too. So the timing is important.
What about people without? What about all of these cases of healthy people having balance issues and things associated with some of these COVID long haulers and everything? Do you have? Do people know what's going on with that?
As you know, right, like a COVID, initially we thought with COVID-19, we initially thought that it's a respiratory tract infection, but that's not true. Many organs and systems, including the central nervous system, can be impacted. So there has been case reports and case series that is already in print. For the long haulers, I think it's basically balance issues and things like that could be caused by a variety of, organ system involvement, and a central nervous system and the peripheral nervous system are ones as well, so that needs to be followed and, discussed and cared for under a physician, especially if the patients have neurological symptoms with a neurologist.
All right. Well, back to kind of what your work specifically is with MS. What do you? And by the way, thank you so much for this. Is the first time that I've really had a MS episode on the show, and it's been wanting to do this for a long time. It's an important subject to me, and I know a lot of listeners are know someone with MS and are going to want to know more. But you've given us such a broad and wonderful overview. Could you share some of the things that you specifically are working on that you're excited about?
Well, two areas, I guess. I'm really excited about the biomarkers. Just as we had discussed, can we get early biomarkers, right? Like at the stage of no disease or after the first episode, can we predict MS, right? And can we predict what kind of outcome the patient will have? Is it a mild disease that can be, treated with a mild, like first line effective, but a milder medication? Or should we be, treating this patient with stronger therapies, right? And also, as you know, after the MS attack, there's some degree of healing or remyelination. But there are also, parts of the brain that have permanent damage. So you do want to predict, right? What's the impact on the nervous system? Should I be putting somebody on a stronger medicine, right? But most of all, I'm very interested in the cognitive impairment in MS because, our cognition, our memory, our thinking is so important, and I think it's appreciated, but not enough, so that's an area that needs a lot of research as well. So I'm really excited about those areas. And most of all, I do think that, right now in the field, we have over a dozen, 15, 16 good medications, but we don't really have a way to, match the patient with the medication. Rather than go from 1 to 2 to 3, if there are some kind of genetic signatures or molecular signatures, either from the blood or from the cerebrospinal fluid, or even by sophisticated MRI scans, right? If we know that if this patient is going to respond best to medication A, B, or C, if we can go to it directly, we don't have to wait until they fail and move on to it. So I think, patient selection, phenotyping, and, therapy, selection is really important. And I think we have all the tools that we need. I think it's basically careful, interaction and working of the MS doctors with the basic scientists, immunologists to develop those tools. And in which case, I think patients will have a really good outcome. So that's from the therapy side. But the other side that, I have learned to appreciate and, learn from the patients who have come to talk to me is the non-pharmacological side, outside of the medicines and the MRIs, the wellness, right? So as I told you, it takes a village to, take care of a MS patient. And, when somebody in the family has MS, it's not just your disease anymore. It has become our disease because it impacts everybody, right? So diet, exercise, wellness, stress management, so those fatigue management, those are the things that you really have to, empower the patient. I see my patients quite often, but at the most I see them every 3 months or every 6 months. But if I can give them the tools to them and to the families, the rest of the year, 365 days, they can practice it, as part of their everyday life. And that I think is really important to emphasize. And I'm sure Megan can share many, many tips and pearls from, throughout your journey. So I think that's one area that I'm really excited about.
This fits really well into my last question, which was kind of for both of you. What are just some tips in terms of research, in terms of people that are listening, have family members have MS themselves. What are some of the best resources that are out? Megan spends a lot of time in these different forums that not only has she gotten a lot from, but she's also been able to contribute a lot to. We mentioned early on, Megan should write a book. Or are there books out there that exist, Mehan, that you think are a really great resource for people? Anything else?
Megan, would you like to go first?
I know the MS Society is a really good resource. Many different spokes to their offerings. They offer financial resources to people. I think, physician resources and things like that. I do think digital support groups can be great, whether that's Reddit or different forums, social media and things like that. There's in-person support groups. I've never been to those, but I know they can be really helpful, and really finding a good care team that cares. My now neurologist is a young woman who will sit with me in her office for 2 hours sometimes. And she has told to me, I can't even count how many times, I don't know. And hearing those words from a doctor, from all the doctors I've seen, is just very impressive. And we will sit there and Google it together. She'll, look up some scholarly resources or whatever. And just, I've had a lot of, I was going to mention this when you were talking about the health piece. In the first year of my journey, all this stuff was going on, all these different things. And I had 120 plus different medical appointments, and probably 80 of those were with doctors. And in not one of those, besides, I think Dr. Bum or my neurologist, did anybody ask me about my diet or exercise, stress, or sleep. The only time that was brought up was when I brought it up. And that has really been pervasive through the rest of these years. The 4 or 5 years I've been doing this, and it's been really disheartening. I am very hopeful for medicine 3.0, should that ever arrive. But it's, a lot of times it's every man for himself, and it's this hive mind and in these groups and talking about, how important exercise and these things are. But I have seen my own physical transformation. I went from joint pain all over my body. Name a joint and it's been affected, to right now where, I can find some pain, but like very, very little. My whole life is just turned around, and a lot of that stuff is, some of it's from pharmacological interventions, but a lot of it is stuff that I've been able to do. And so as far as resources, I think, using each other, like you were mentioning, peer-to-peer stuff, and finding a good care team, that really cares. And I know that I don't blame the individual doctors. I blame the system. I blame the pressures that they're up against, and they've got 15 minutes to jot down as many notes as they can to get this appointment, covered by the insurance and stuff. And it's just the state of our healthcare system. But we can use resources like podcasts. I have learned, like Shane's podcast, which has led me to other things, and other, I've just learned so much about health and the human body, and which has helped me reestablish my priorities in a day or in general. And so there's a lot of resources that we can tap into, and not all of them are good, and there's bad information out there. But as far as like specific stuff, I don't know. I don't know.
I think you covered a lot, and I think it's also, really, I would like to encourage you as well to share what you know, right? Even if you're not sure, to run it by your doctor. Because, I've had, I'm Western, I'm trained in the, Western system. So that's what I knew. But I also have opened my minds, because patients have come and asked me questions, right? And if I don't know, I look up, right? And also you see these patients before and after, right? So I think you also, and it's also a no-brainer when you think about it, right? Like a diet is the biggest medicine that you put inside your body every day, right? So if you want to have like healing and repair, or even wear and tear, right? For wear and tear, you have to give good raw material if you want to heal, right? So things like that. If somebody sat down and spent 15 minutes or 20 minutes explaining to you, you get it, because it's already a known fact. But coming from a doctor, I think it matters a lot. So I always try to do, after the diagnosis, once the patients are on the right medication, for me, that's paramount, But once we have that, I would sit down and talk about symptoms and symptom management, lifestyle modification, and even sitting down with the family members or whatnot, and how are the caregivers doing, are they getting along well, the social, emotional, psychological aspects of it. I encourage them to talk to people, spiritual, emotional support comes in many ways for many people. Sometimes for some people it's running, for other people it's music, or art, whatever it may be, to find your, source of strength where you can, replenish. And diet is paramount. We're really lucky, though. We have a group called the Integrative Medicine at Stanford. So, at least I know that when I refer them to my colleagues, my patients will have the sound, legitimate knowledge and information. Because part of it is also not because we believe or don't believe. There's not enough science, right? Because people haven't done thorough research, on these topics. So, our group worked very closely with the ancillary care, so integrative medicine doctors, other symptoms that come with MS, physical therapy, occupational therapy, psychotherapy and counseling, bladder care, bowel care, vision, so all of those. So that's why in a lot of the MS centers, you have those ancillary care like tapped into one. But I really like, when people give a talk about nutrition, not just like, go with the Mediterranean diet, the food pyramid and whatnot. How do you repair myelin? What are the components that you're needing? What are the elements, from a legitimate source, I think is really important. Exercise is also really paramount, right? You just can't say go exercise, because it's not the cardiovascular type of exercise. So, is it stretching, core strengthening, balance exercises, weight training, cardio, and how do you put all of those together? So some of the physical therapists who work with patients who have neurological issues, they're really facile in, integrating and developing a exercise program. The rest, you just have to, see what works for you and what you like, because only then you'll be able to maintain it, So I'll stop here,
I was going to ask. Oh, sorry.
Mm-hmm. Go ahead.
Well, I know that there's a couple, and this is back to the therapeutics, but you got me thinking when you're talking about diet and remyelination, because I think that's really fascinating too. But I've been loosely following, trying not to get to, until it goes to phase 3 and there's a little bit more promise, but on these remyelination therapies and how that, that could be a complete game changer. And I know there's one with metformin and clemastine fumarate or something. And I happen to be on metformin for PCOS. And there's been a lot of interesting stuff coming out about metformin with longevity and this, and this. And I was like, yay, if there's a bonus there for, I could tap into some, patching some stuff up in there. I don't know. But are you hopeful for these therapies?
Yeah, very, because I think we have a lot of good immune therapies, but not so much from the repair side. But I do think that in some ways, it's not like, inflammation and neurodegeneration occur in silo. So there's inflammation and there's ongoing repair. So you have to have a way to control the inflammation, either in terms of induction or continuous therapy or whatnot, while trying to promote remyelination or repair, right? Or even preventing neurodegeneration. So while all these studies are in clinical trials, we're very hopeful, but, keep exercising. Exercise is the best way you can, repair the brain, rewire and recharge the brain. That's one of those. We talked about diet and even doing exercises that are, that take part, like that part that coordinates different part of your brain. That's why people say, right, learn a new instrument, learn a new language. It doesn't have to be it, but if you, if you switch, if you basically use different parts of the brain for a function that you don't normally do, that would trigger brain growth or repair.
Yeah, but since the beginning, I've had this kind of thought that I'll get on this drug. That'll kind of hopefully hold me over, or, do as much as it can. I'll do what I can, I'll take on some heavy lifting and hopefully buy some time for maybe the next best thing, whether it's remyelination drug or my own doing, allowing space in there for healing to occur, tamping down inflammation and allowing, the natural remyelination to occur. But yeah, I think it's a multifactorial approach that might yield better outcomes. I don't know.
So this has been I'm sorry to cut it short, but I know May she has a meeting she needs to jump to in like 3 minutes here. So I just want to make sure and let her go right away. But Megan, thank you so much for joining in and sharing your personal experience and taking part. This is really fun and awesome. May, thank you so much for your time and all of your incredible research and everything that you do for humanity. And I know from trying to book you on this show that you have an insanely busy schedule. Here we are on late on a Saturday night recording a podcast before you go and jump off into a conference call. So you're incredible. Thank you. Thank you for everything.
Yeah, thank you so much.
It is a privilege, and an honor to walk this journey with you all. I'm every day humbled by watching, people who do so well despite what they have. And I always say that they're my teachers and they give me the energy and the insight and the drive to do more. So thank you for what you do. And Shane, thank you for putting the pieces together so that we can have this incredible forum, discussing about something I'm really passionate about. So I truly appreciate both of you.
This is so great. It was fun and it's super important stuff. I know my listeners are going to love this. And thank you, listeners, for being such wonderful, curious people. We'll talk with you more next week.